Hi, and welcome back to the Blood Bank Guy podcast. This is Joe Chaffin. This is actually part 2 of this podcast. The first part, which is found on iTunes under the name Intro to TTDs, was recorded just a few days ago, and basically it was an introduction. It went over the general philosophy behind transfusion-transmitted disease testing. It went over the basic screening test descriptions, and we also did some basic terminology. So that leaves us with today, where we're going to talk about the specific organisms. So we have a lot to talk about today, and I would really urge you to go to the Blood Bank Guy website, which is www.bbguy.org. Click the podcast tab and go to TTDs, and you will find a downloadable handout that's in PDF format that follows this lecture, as well as the preceding lecture on the Intro to Transfusion-Transmitted Diseases. So please check that out. I think it'll help. So let's move along. So a couple things that you need to know about transfusion-transmitted diseases. Basically, there are some requirements, I should say, things that have to be present in order for a TTD to actually cause disease. First, there has to be an asymptomatic phase in the donor. We ask every donor how they're feeling. They generally self-defer if they're feeling badly, or if we notice that they're not feeling well, we will defer them at that point. The agent has to survive in donated blood. That seems rather intuitive, I would say. The route of transmission for the organism must be intravenous. Again, that makes sense. The recipient has to be susceptible. So in other words, if an organism goes in and the recipient is not susceptible to it, then obviously you're not going to see any disease. And that goes along with the last one, which is that there has to be detectable disease in a recipient in order for a TTD to be a TTD. And again, I think all of those make sense. With that in mind, let's move on and let's talk about what I call the classic TTDs. Now, classic is really a misnomer a little bit in this terminology, because some of these have not been around for that long, at least in terms of our knowing that they cause infectious disease. Some of the organisms that we're going to talk about today include syphilis, hepatitis B, hepatitis C, HIV, of course, HTLV, West Nile virus, CMV, and Chagas disease, or T. cruzi. I'm not going to say enormous amounts about some of these, again, because I'm going to try and focus on the most important ones, but we'll hit a little bit on all of them as we go through. So let's start with syphilis and talk a little bit about syphilis, which actually was the first transfusion-transmitted disease that we were really aware of. Back in the 1940s, we discovered individuals getting syphilis after the rudimentary forms of blood transfusion that were present, and in fact, it was the first blood testing that was done on any units of donated blood. Syphilis, as you know, is caused by Treponema pallidum, which is a spirochete. You shouldn't expect to see the 3 disease stages that you see when syphilis is an STD in blood recipients that get syphilis. Now, truthfully, this so very rarely happens. It's extremely low frequency. The disease is, anyway, in the general population, and the organism doesn't survive in the blood. So it's been years and years, literally decades, since we have a documented case of transfusion-transmitted syphilis. But we're still required to test, according to the FDA, and there are 2 basic types of testing that we do, or that we can do for syphilis. The first is the non-treponemal type of testing, which is very nonspecific. It's actually not looking for syphilis at all. It's actually looking for an anti-cardiolipin antibody. The unique thing about non-treponemal testing is that it stays positive until the patient is treated for the syphilis. That kind of makes sense, but treponemal testing, on the other hand, is very specific. It's looking for an antibody against the spirochete itself, and generally positive treponemal tests stay positive forever. Quickly on the non-treponemal test, the RPR and the VDRL test that most of us have heard of for a long period of time, both of those, since they're non-treponemal, look for anti-cardiolipin. RPR is a little simpler. Both of these tests lack sensitivity, they lack specificity, so a wide variety of, the majority of people that test positive are false positives with the non-treponemal test. Things like pregnancy and rheumatoid arthritis and ulcerative colitis. In fact, HIV can give you a false positive non-treponemal test. Tuberculosis, things like that will give you non-specific false positives. Here's just a picture of a reactive VDRL, or what it would look like. VDRL is done on glass slides and wells on a glass slide. Anyway, moving on, let's talk about treponemal tests, which are specific, as I mentioned before. Kind of the one that people know of and have heard of is the FTA, the fluorescent treponemal antibody absorption test, FTA-ABS test. Honestly, not used all that much. It formerly was used as confirmatory for a reactive RPR or VDRL. Nowadays, in blood banks anyway, we're using hemagglutination much more. The treponema pallidum hemagglutination test, or TPHA, is done very commonly on one of the most widely used instruments in blood donor testing, and that's the Olympus PK7200. It's used with a variant. It uses chicken RBCs and basically screens with the antibodies bound to the chicken RBCs, screens for hemagglutination. Now, the TPPA, or particle agglutination test, is thought by the FDA to be the best confirmatory test because it has fewer false positives than any other test. TPPA basically uses the antigen bound to gelatin particles. And there is an EIA, by the way, that we talked about before. We talked about EIA in general before, which is available for T pallidum as well. Most places nowadays, in terms of blood centers, will use hemagglutination as the screen and particle agglutination as the confirmatory test. Here's just a picture of a reactive VDRL up on the top left. Again, not terribly difficult to see. And I've already mentioned that's what things are typically done. Now, in terms of results management, if a donor is confirmed positive for syphilis, they are deferred for 1 year from the time of the treatment completion. Now, some people will decide to just go ahead and permanently defer donors in that situation. You certainly can do that, but if the donor is treated, theoretically, they can be re-entered, or they can resume donating again 1 year following treatment completion. However, if it's not confirmed, in other words, you get a reactive screen but not a reactive confirmatory test, realistically, they can donate again at their regular interval, theoretically. Again, that's up to the medical director, and the medical director can decide to do that whatever they want, whichever way they want. That's all for syphilis. Let's move on and talk about hepatitis B, because that is obviously a far more important phenomenon for us. Hepatitis B has been around for a long time, and you see on the slide that it was first discovered in soldiers in World War II with post-transfusion hepatitis. But the big breakthrough for hepatitis B was the discovery of surface antigen, hepatitis B surface antigen. So the so-called Australia antigen was discovered in 1965, and in 1970 we were able to begin surface antigen testing on the blood. Anti-core testing was added later on, not necessarily for hepatitis B. We'll talk about that in just a few minutes. And you can see the last two bullets there. The amount of hepatitis B has been decreasing in the United States over the last 20 years or so. Here's a picture of hepatitis B. It is a DNA virus. It is enveloped, and you can see the DNA in the core of the virus in the picture on the right. Interestingly, it's a DNA, but it has an RNA intermediate within the hepatocytes, and that RNA intermediate is, when it's transcribed back to DNA through reverse transcriptase, it's actually very inaccurate, and you can get variations of the genetic code with hepatitis B. It's one of the things that makes it a little bit elusive. Again, here's another image, just a schematic of hepatitis B, and there's a couple things I want to call your attention to. First, on the first arrow that will pop up will show the presence of free-floating surface antigen, and that's something that is very unique to hepatitis B, and it really enables us to get a very good look at whether or not hepatitis B is present in the blood or not. There's kind of a natural amplification as hepatitis B is being formed within the hepatocytes, that you end up with this outpouring of excessive hepatitis B surface antigen. It's certainly more than the virus needs to replicate itself. Again, it's kind of a natural amplification. That amount of hepatitis B surface antigen is detectable, and it's one of the reasons that that testing for hepatitis B using surface antigen testing is probably pretty close to as good as what we would get if we did nucleic acid testing. The second thing to notice is the hepatitis B core antigen, and again, that's present in a core around the area where the viral DNA is. All right, so what is hepatitis B clinically? Well, it has an incubation period somewhere in the range of 8 to 12 weeks. That varies. The difficult thing for us in the blood donor setting is that 65% of individuals with hepatitis B are completely asymptomatic. It's very uncommon to be like this poor patient on the picture on the right side and be a fulminant infection. One other thing you should be aware of is that the younger that you get hepatitis B, the more likely that infection is to be chronic. Hepatitis B, as you're well aware, I'm sure, is transmitted parenterally through IV drug abuse, some sexual transmission, blood and body fluids, etc., and you can see them all there. Again, I mentioned this earlier, the incidence of hepatitis B is decreasing in the United States, down to a considerably smaller number than it used to be. And again, you can see some of the changes that have come about in recent years, partly as a result of our ability to test for it. Now, in terms of the risk from transfusion, historically we used to say that when you consider all blood donors, there was a risk of about 1 in 144,000 transfusions of a recipient receiving hepatitis B. That's not great, to be honest. It's better for first-time donors, for repeat donors, the 1 in 205,000 number. Currently, though, actually a study published in Transfusion in 2009 showed that the risks were actually better than we had thought we were before. About 1 in 355,000 is the risk, and again, that's considering all donors. So again, we've gotten better, but when we talk about some of the numbers for HIV and hepatitis C, for example, you're going to see that we're not nearly as good as we are with those viruses. So the tests that we use in the blood bank include hepatitis B surface antigen, of course, which is done using an EIA or chemiluminescent test, anti-hepatitis B core, again, same technology, EIA or chemiluminescence, as well as in some cases, it's not required yet, as well as in some cases, we do a nucleic acid test for hepatitis B. Again, that's dependent on the laboratory. FDA has not yet required it. I expect them to do that in the fairly near future. Here's just a look at how hepatitis B virus testing goes. And again, I'm sorry that I don't have a laser pointer that I can point to your screen so that I can show you that. But if you look at the very first, starting from the far left of the picture, the very first thing that goes up and comes back down is the presence of viral DNA. And that is certainly very early in the infection. But you notice the second curve that goes up and comes back down is the presence of surface antigen itself. And again, that natural amplification that we mentioned earlier is one of the reasons that NAT is probably not a ton better than surface antigen. Moving on to the 1, 2, 3, 4, 5th curve, that is the amount of anti-hepatitis B core with IgM, and total anti-hepatitis B core comes up a little bit later on. Again, anti-core is not the greatest test in the world for hepatitis B, and as we'll talk about in just a second, it was actually introduced for something else. Now here's the hepatitis B surface antigen test. It's an EIA chemiluminescence. It's the first testable marker currently required that's positive. It has a shorter window period, about 4 to 8 weeks, through using the surface antigen test, and that surface antigen often disappears by 4 to 6 months unless the donor or the patient has chronic infection. Not all that common. The confirmatory test for surface antigen, we talked about this in part 1. Actually, I don't think we did, come to think of it. I'm sorry about that. The confirmatory test is a neutralization test. Basically, you run the exact same test again after adding reagent anti-HBs. So again, if there is surface antigen floating around in the patient's sample, in the donor sample in this case, then the reagent antibody will neutralize that antigen, leaving less to react in the test. So a 50% decrease in the strength of the reaction it equals neutralization, and the individual is considered positive for surface antigen. Now, anti-core, as I mentioned, is another test that we do. It's a total antibody test, both IgG and IgM. It was initially introduced as a surrogate test. Basically, we knew that there were people that were still getting post-transfusion hepatitis, and we knew that hepatitis B didn't explain everything. So non-A, non-B hepatitis, what we now know as hepatitis C, is one of the reasons for the introduction of anti-core, but also, interestingly, it was considered initially a surrogate test for the presence of HIV before we had HIV testing available. Anti-core is just an EIA, and it has a longer window period. It's nonspecific, a very important number there. Less than 1% of people who are positive for anti-core alone have a positive NAT. So it was considered, in addition to the surrogate test, it was considered a marker for a very short window period. Here you see that window period on this slide, which shows it represents a period where the surface antigen test has decreased. That's the purple arc on the left. It goes up a little bit before 4 weeks, comes down a little at about 22 weeks. So it's a period where the surface antigen is gone, or near gone, and the yellow line on the far right, the presence of the antibody, which would be protective for the donor, it has not formed yet. So there's a window period in there where the only thing that would be positive would be total anti-core, and that was one of the reasons that that test has been continued for an extended period of time. Very, very rare for this to be an issue, so let's not talk about it anymore. Now, I mentioned before NAT is not currently required. It's done using mini pools, and so sensitivity is not much more than surface antigen. Has a 3 to 6% false negative rate, surprisingly, and so we traditionally have thought that this is probably not as good, not as great a test as it is for HCV and HIV. But there was a study that came out in the New England Journal in January of 2011 that cast some doubt about that. It may be somewhat better than we thought. Still to come on that. Now, again, in terms of deferrals, if an individual has a history of hepatitis B infection, even if it's resolved, they are permanently deferred from donating blood. Another weird one that I just can't understand is that if an individual has viral hepatitis of any kind after their 11th birthday, even if it's hepatitis B and hepatitis A, and it's completely resolved, doesn't matter. Any viral hepatitis after that 11th birthday is a permanent deferral. Talk to the FDA about that one. Finally, individuals can be deferred for hepatitis B based on test results. And here's a big kind of busy slide, and I apologize for that. But let's start from the top. If individual who is positive for or reactive, repeat reactive for anti-core only with negative surface antigen, negative NAT, would not be deferred the first time that happens, but then would be permanently deferred the second time that happens. There are some reentry possibilities that we'll talk about in the next slide, but it is an indefinite / permanent deferral. Okay, the second line down shows a reactive surface antigen alone. What happens with that donor depends on whether the test neutralizes. If neutralization is positive, it's a permanent deferral. If it's an indefinite deferral if neutralization is negative, and after 8 weeks, if the medical director of the facility approves, the individual can be retested. So that used to be a longer deferral before retesting was allowed. Reentry is not automatic. Individual facilities can make up their own minds on that, but that's what can happen. The third one down is if you have a reactive anti-core as well as a reactive surface antigen. If that happens, you're done. It's a permanent deferral regardless of what neutralization shows, as well as regardless of whether it's a first or a second core. Now finally, the last one, according to the FDA, if an individual does have NAT done and it's reactive for hepatitis B, it's a permanent deferral. And that's actually surprisingly different from what would happen with HIV or HCV in that situation. More on that in a minute. Anti-core reentry was implemented in May 2010 through an FDA guidance. It's for those deferred due to the presence of anti-core alone. It requires you to do anti-core testing, surface antigen testing, as well as NAT HBV after 8 weeks from the prior second reactive anti-core test. If all those are negative, then the individual can be re-entered. Some people are doing this, some people aren't. It's kind of up to the individual facility. Now moving on and talking about hepatitis C. Basically, with hepatitis C, we've known it's been there for a long time. We didn't know exactly what it was until it was identified in 1989. And in the 1990s, we kind of went crazy with a major look-back effort to try and identify anyone who might be infected with hepatitis C through previous blood transfusions. It wasn't all that successful, but we did find some donors in that category. Now, hepatitis C, unlike hepatitis B, is a single-stranded RNA. It is enveloped, just like hepatitis B, has a core antigen like hepatitis B, but as I said, it's a single-stranded RNA as opposed to a double-stranded DNA. The incidence of acute hepatitis C has greatly decreased in the United States since the discovery of the virus itself, and you can see the decrease on the graph on the left, a huge decrease in the amount of acute hepatitis C. And based on CDC data, you can see on the right the incidence per 100,000 is dramatically decreasing as well, though we've had a little bit of a bump since 2005, and more on that in just a few minutes. Hepatitis C, like hepatitis B, is parenterally transmitted, majority due to IV drug abuse in the United States now, less sexual transmission than with hepatitis B. And again, you can see some of the other issues that could lead an individual to have an increased risk for hepatitis C transmission. The multiple sex partners thing, not because of sexual transmission, but because of other lifestyle choices that puts one at potential risk for HCV. Now, hepatitis C, unlike HBV, is 80% chronic. So the majority of individuals develop chronic hepatitis C, and of those 80%, 30% of those have stable infections, 30% of those have severe infections, and 40% of them it can go one way or the other. It takes a long time for hepatitis C to become symptomatic. A lot of people, sadly, walking around that are positive for hepatitis C that don't know about it. It takes about 10 years to develop chronic symptomatic hepatitis with HCV. Cirrhosis takes about 20 years, and in the few people, thankfully, that get hepatocellular carcinoma, it takes somewhere in the range of 30 years. Current treatments are much better at treating hepatitis C, and 42 to 82%, so 40 to 80% or so, do respond to treatment. And here's just a picture of some of the things that can happen. On the left, obviously a healthy liver on top, so a horribly cirrhotic liver on the bottom, and on the right, a picture of hepatocellular carcinoma, which is, again, just awful looking. The risk, again, according to an article in Transfusion in 2010, the risk has been shown to be about 1 in 149,000, 1,149,000 transfusions. Not as good as what we used to think. We used to quote a number about 1 in 2 million, but this study was based on a large number, on a large sample size, and took into account some things, including the recent slight increase in incidence in the United States. And we come up with this number, which again is considerably better than hepatitis B. In terms of our testing, we do an anti-HCV test, which is an ELISA/chemiluminescence test, introduced in 1990 as version 1.0, now version 3.0. And we talked about this a little bit when we talked about REBA in part 1 of this podcast. The 3.0 refers to the collection of antigens that are present in the test kit, which parallel between the ELISA and the REBA. The window period, unfortunately, with ELISA testing, with EIA testing, is quite long, 70 to 80 days. Some report even higher than that. REBA, as I mentioned, is confirmatory. So as a result of that very, very long window period, we have looked for quite a while and have in the last decade or so have come up with a test that's considerably better, and that's nucleic acid testing. The presence of HCV RNA is considerably earlier than the anti-HCV, than the antibody. So if you can look on this particular image and you can see that the antibody actually doesn't start going up until about 3 months or so after exposure. The RNA is present far earlier. You can't detect it exactly as early as it's present, but you can detect it considerably earlier. And let me show you that. HCV NAT was introduced in 2001. Knocks the window period down from that very, very long window period down to 20 to 40 days. Unfortunately, even though this makes a lot of sense and it seems logical, we actually end up with a fairly low yield. Only one positive NAT per 240,000 anti-HCV negatives. So those decreased window period infections that we would expect to see a decent number of, there's not a whole lot of them, and it's probably because of the relatively low risk in our donor population. Can be done, NAT is done using reverse transcriptase PCR or TMA, and it's done in mini pools and then identified if the pool is positive. Okay, so for hepatitis C testing, a couple things that you need to be aware of, and let's take a look at what happens to our donors when they are positive for specific things. So let's look at look first at the NAT and EIA results and decide what's going to happen with the donor. So if a donor is HCV NAT positive and EIA positive, they're permanently deferred, and that just makes sense if you get both positive, and that's true regardless of what the REBA shows. Second, if the NAT is negative, okay, so negative NAT, positive EIA, but a negative or indeterminate REBA. So in other words, you have a non-confirmed EIA test. If that happens, the donor gets an indefinite deferral and may attempt to re-enter in 6 months, depending on the will of the medical director, whether or not they'll be allowed to do that. The next situation is the same, except that the REBA confirms the donor as HCV positive or anti-HCV positive. Those donors are permanently deferred. The next one is somewhat odd. This is where you have a positive NAT and a completely negative EIA, so a positive NAT and a seronegative donor. Those donors actually get the same treatment as the donors with in category 2 that we showed. They're indefinitely deferred. They may attempt to come back in 6 months, but it's not guaranteed. It's up to the individual facility. They have to be retested in 6 months or in more than 6 months if they're going to be re-entered. And here's how that works. It's optional, not required, as I said. It's done on a sample, not on a donation. In other words, they can't come in and start donating again automatically. If you're going to re-enter them, they have to do a sample first. So you have to do some specific FDA licensed tests, including individual donor NAT, in other words, non-pooled NAT looking for HCV, as well as an EIA or chemiluminescent assay. If those results are, this next slide shows it basically, if those results are anything but completely negative, then the donor is not going to be allowed to re-enter. The one exception to that is if they get the same results, negative NAT, EIA, that's not the same results. Negative NAT, positive EIA, they get an indefinite deferral and may attempt to re-enter in 6 months. But if everything is completely negative, then you can re-enter that donor and they can be allowed to go on and donate once again. All right, moving on to HIV. Obviously, everyone knows a lot about HIV, so we're not going to spend a ton of time on this. Where did it originate? Nobody's really sure. Maybe the Congo. We certainly started seeing it in the United States back in the late 70s and early 80s in San Francisco and New York. Excuse me, let me go back. It was discovered jointly by Gallo and Montagnier in 1984. They called it different names. And we know now that there are two main species of HIV, HIV-1 and HIV-II. HIV-1 has three main groups, Group M, which is the main group and is the primary type seen around the world. Group O is the other one I would call your attention to because it's present in West Africa, Sub-Saharan Africa, and it has caused us to alter our testing just a little bit. So here's a couple images of HIV, kind of a complex looking virus. It is an RNA virus, obviously, as a result of the fact that it has RNA as well as reverse transcriptase within the core. GP120, GP41 are important external molecules, as well as GP160 that we'll talk about in just a little while. HIV-II, real quickly, not a whole lot to say about it. Was discovered in 1985, present in West Africa and Europe, and honestly doesn't cause us a lot of issues because it's very rarely seen, and even if there, it's thought to not cause as severe clinical consequences as HIV-1. Transmission of HIV is sexual, as we're all well aware. The donor group, not just the donor group, the group in general with the highest incidence of HIV is male individuals who have had sex with other males, as well as high-risk females who have had high-risk sex, whether that's with males who have had sex with other males or multiple partners. It's also obviously transmitted parenterally through IV drug abuse and transfusion before we knew about it, as well as can be transmitted vertically through childbirth and breastfeeding. And here's just an image of what I mentioned before, and this is CDC data that basically shows that in 2006, yes, it's somewhat old data, but the prevalence of HIV is by far highest in the population of males who have had sex with males. Another alarming statistic from the CDC, however, is this one, which shows the incidence, the relative incidence in both males and females in various racial populations. And as you can see, a huge issue in the African American population, especially young African American males, where HIV is and has spread enormously and dramatically. A very, very concerning thing there. All right, for HIV disease, the incubation is about 2 to 4 weeks. Individuals have very mild symptoms, often just kind of flu-like symptoms, but they may not feel well at all. The window period, on the other hand, is 10 to 11 days. Remember, window period is time from infection up to the time when we can tell that the person has been infected. In other words, we can detect it in the laboratory. Unfortunately, there is a cell-free viremia in this time, and individuals are capable of transmitting the virus through the window period. There's an asymptomatic period for HIV that's very long, very extended, as the CD4 count gradually declines over time, and then finally the presentation with AIDS, and individuals with AIDS will die within 10 years if untreated. But treatment obviously has improved, and individuals are seeing much, much better results with treatment nowadays than they were in previous years. All right, so HIV-1 risk, wow. If you're going to ever choose a time or place to be transfused, San Francisco in 1980 is probably about the worst I can imagine, because the odds The risk of HIV in San Francisco in 1980 was 1 per 100 units transfused, a terrifying number. Currently, though, obviously we're doing far better than that. 1 in 1,467,000 units, again, according to that transfusion article from 2010 I referenced earlier. The risk is almost zero for HIV-II. And you can see that illustrated. The same morbidity and mortality weekly report that I alluded to in part 1 of this podcast had a chart showing transfusion-transmitted HIV reported to CDC in the years since 1985. And again, you can see very, very uncommon, does not happen often at all. Our testing for HIV uses first an EIA, or chemiluminescence. It's the anti-HIV 1/2 test, has a window period of about 20 to 22 days, which by itself is not great, and we've worked to decrease that. Initially, we worked to decrease that through the use of P24 testing, but now we'll talk about what we do with NAT. Also, you should be aware, and I don't mention this on the slide, is that the test for anti-HIV 1/2, most of them that are licensed and on the market in the United States now also detect HIV group O. Very, very important for us. It keeps us from having to ask a multitude of questions about donors who have traveled to or had contact with individuals from Africa. The confirmation for anti-HIV is Western blot, and we talked about this in part 1. A positive means P24, GP41, and GP120/160. Indeterminate means not all of those, and negative means none. IFA is something that I talked about again in part 1. Similar sensitivity, fewer indeterminates. We're also, by the way, when you get a reactive anti-HIV 1,2, you're required to do an anti-HIV-II ELISA, which is required but is very low yield. Now, NAT, on the other hand, gives us a much better window period. Rather than 20 to 22 days, NAT knocks that window period down in half to about 10 to 11 days. Now, despite the fact that that seems good, it has a considerably lower yield than the NAT for HCV. NAT HIV is only positive in 1 per 3.1 million antibody negatives, seronegatives. So not a great yield, but felt to be worthwhile by those who make those rules. Let's leave it at that. P24 I mentioned is no longer required. It decreased the window period as well, but NAT has kind of taken its place. Here's the testing pattern for HIV, and again, you see the first thing that comes up with that shorter window period is the presence of HIV RNA. This particular chart or table is showing. It's actually a graph, isn't it? It's showing HIV RNA with reverse transcriptase PCR, but it's similar with TMA. Again, so P24 antigen comes up after that. DNA through PCR comes up after that. HIV antibody, you see, takes about 20 to 22 days before you start to see it. So most important to remember the RNA, the first curve, and the blue curve, which is the last one to come up, which is the presence of antibody. All right, so let's do the same thing that we did with HCV for HIV, and you'll see that these are very, very similar parallel type donor decisions. First, both positive, both NAT and EIA donors permanently deferred. Second, the presence of only a positive EIA without a confirmed Western blot or IFA. Same deal, it's an indefinite deferral, but rather than having to wait for 6 months before they're retested, these donors only have to wait 8 weeks before they're retested. Remember, 6 months wait for HCV, 8-week wait for HIV. If, however, the EIA is confirmed positive, then those individuals are permanently deferred. And finally, the same sort of thing with a positive NAT, negative EIA, they get the same treatment. They're indefinitely deferred, and they may attempt re-entry again in 8 weeks. Now, with the re-entry testing, again, the only way they're coming back right away is if they have negative for both, then the donor can be re-entered. All right, moving on. Let's talk about HTLV. HTLV was actually discovered before HIV. In fact, HTLV-1 was the first known human retrovirus, and HTLV-II was the second known human retrovirus. And that's the reason that HIV was originally called HTLV-III, because it was the third known human retrovirus. Anyway, HTLV-1 and 2 are very similar. They have 60% homology. They are cell-associated viruses. Very important for you to remember that. They're not floating around in the circulation much or in the plasma much. They're living within white cells, probably within the lymphocytes. First HTLV-1 is found, as you can see on the map here, it's found in Africa, South America, Central America, you can't see that very well, and as well as a very large population of HTLV-1 infections in Japan. There are two main disease associations with HTLV-1. The first is ATL, or adult T-cell leukemia lymphoma, and the second is HTLV-associated myelopathy. Let's talk about ATL first. It's a very aggressive T-cell malignancy that kills people fairly rapidly. The unique features about ATL is the fact that the spleen and the liver are involved very early and very heavily, and these patients present with hypercalcemia. So despite the fact that these folks don't do well at all, and that it sounds really scary for individuals who are HTLV-1 infected, the truth is that the vast majority of people who are truly infected do not get ATL. 95 to 99.75% of those who are HTLV-1 infected don't. And in fact, there have only been 2 cases of reported transfusion-transmitted ATL from HTLV-1 infection. So not a very common problem for us, though obviously we do have to test. Here's just a picture real quick for those of you that like your hematology. These are the so-called daisy cells. I almost couldn't remember daisy cells that are classic for HTLV-1 infection and ATL. Now, HAM, or HTLV-associated myelopathy, used to go by the name tropical spastic paraparesis. It's basically a spinal degeneration. Lateral and posterior columns degenerate, you get leg muscle spasms, loss of sensation, and there isn't an effective therapy. But again, the good news is that it doesn't happen very often in individuals who are HTLV-1 infected. Transmission is parenteral for HTLV-1, though it's very inefficient. Look-back studies have shown us that individuals who get blood from previously undiagnosed HTLV-1 infected individuals usually don't even get the virus itself. If they do get the virus, very uncommon for them to get disease. It's transmitted best through IV drug abuse, can be maybe through breastfeeding and maybe sexual, but the issue is that even though it's not a huge deal for us in the United States, there are 10 to 20 million people infected worldwide, though again, very rarely do those folks get disease. HTLV-II, on the other hand, is thought to be seen, it's actually seen quite prominently in the IV drug users in the United States, as well as in Native Americans in the United States, but fortunately HTLV-II doesn't cause much in the way of disease. There's no association with adult T-cell leukemia lymphoma, maybe some association with HAM, but probably not. The risk that we've said traditionally based on a 1996 study was 1 in 641,000 transfusions, which is pretty good. But truthfully, now since we pretty much universally leukocyte-reduce blood, the risk is much, much less, thought to be about 1 in 3 million transfusions. Testing for HTLV-1 and 2 has been around since 1988. It's an EIA, or chemiluminescent test. It uses a viral lysate. There is no licensed confirmatory test. Very important to remember that. There are confirmatory tests out there. You can do unlicensed Western blot, unlicensed RIPA, but despite that, there is no licensed FDA licensed test, which means basically you can't re-enter someone, for example, based on the fact, oh, well, they didn't confirm as positive because the FDA doesn't recognize any confirmatory test. You may confirm a reactive HTLV-1/2 ELISA with a second test using a different test kit, but most people handle it this way. You get one reactive and you are not required to defer the donor. In fact, you're not even required to notify the donor, but most people do. If you get a second reactive on a second donation, or if it's a repeat of the original test, then you're permanently deferred. Unfortunately, those conversations are not easy and not fun because nobody really knows what to do with HTLV tests, especially since you can't do an FDA licensed confirmatory test. All right, let's move on and talk about CMV. CMV is kind of a big deal for us. It's a DNA virus and a member of the herpes family. For most of us, it causes very mild disease. If you're healthy and you're CMV infected, as over half of us have been at one point in our life, it's probably just a cold for you. However, in at-risk populations such as transplant patients and babies getting fetal blood transfusions, low birth weight babies, as well as immunodeficient patients, those at-risk patients have a big problem with CMV. If you're CMV negative and you're in that population and you get a CMV infection, you can get hepatitis, pneumonitis, retinitis, encephalitis, blindness, deafness, mental retardation, all kinds of horrible stuff. So it is important for us to be aware of it and try and prevent it as best we can. A couple images just to show. The bottom stuff is just showing some of the areas where CMV can be a problem. The top is, I used to be an anatomic pathologist, so I like showing AP pictures. This was from an esophageal biopsy, I believe, that showed the presence of the classic owl eye inclusions from CMV, but also in that very large cell with the owl eye, you also see some cytoplasmic inclusions. Note that the cell is much bigger than the surrounding cells. Remember, it's Cytomegalovirus. So the cell gets big, the cell gets inclusions as well. Okay, enough of that. Sorry about that. In terms of risk reduction, there are basically two strategies that we use for CMV. The first, and the traditional way, was to use CMV seronegative products. In other words, we tested our donors for the presence of an antibody against CMV. If they were negative, then they were called CMV seronegative, and their blood was given to at-risk recipients. On the other hand, leukocyte reduction has been thought for some time now to be pretty close to equivalent to CMV seronegative. And again, the rationale there is that leukocyte-reduced products, remember the virus lives within white cells, it's just a white cell virus. So if you get rid of the white cells, 99.99% like leukocyte reduction does, it's thought that that decreases the risk very, very substantially. However, here's the truth. Both CMV seronegative and leukocyte-reduced products, there's no complete elimination with either one. Both have a small, like 1 to 4% residual risk of infection, and it's probably as a result of the fact that in very acute infections for CMV, a blood donor in our case who is acutely infected with CMV, the virus actually has a very short period during which it does float around in the blood and it hasn't gotten into the white cells yet. So leukocyte reduction wouldn't help. And as a result of the fact that it's a very early infection, they might not have formed their anti-CMV antibody yet. So either strategy would be missed, and that's probably the donors that are at risk for transmitting CMV. Testing that can be done for CMV includes EIA for antibody detection, hemagglutination, which is done on blood analyzers, and in fact is the most common way that blood donors are tested for CMV in the United States right now. NAT is possible, it can be done, but it's not required, and it probably doesn't help a whole lot more. All right, quickly as we move along, we're starting to get short on time, so I'll finish these as rapidly as I can. West Nile virus first became an issue for us in the United States in 1999 with an outbreak in Queens, New York. And from that focal point in Queens, the virus has spread westward in a very rapid seasonal pattern over the course of the next few years. In 2002, it was proven that West Nile could be transmitted through transfusion as well as through organ transplant, which was one of the places it was first found. The industry came up with a nucleic acid test, which was done under investigational new drug device from the FDA in 2003 and formally approved by the FDA and required in 2005. West Nile virus itself is an RNA virus which undergoes a life cycle within birds, and as a result of repeated bites from mosquitoes, and we're just an incidental host for West Nile. We just happen to be in the way. Okay, so these images, the first one on the top left shows how in 1999 in red, the states around New York and New Jersey started seeing incidents of West Nile virus, and as you can see from the chart, the virus moved to the west over the next 3 years or so. The image on the right shows the primary transmission cycle in birds and how humans and horses are just incidental hosts. And finally, the bottom chart shows in 2008 the number of viremic blood donors, and not very many left. Very, very few, except for in the West Coast, the California coast, as well as in Arizona. So much less of an issue now than it used to be. Here's the deal with West Nile. 80% of people with West Nile are completely asymptomatic. About 20% of those with West Nile virus get what's called West Nile fever, which is very mild, and 1 in 150 get meningitis, and a few of those get encephalitis, and a very few of those have fatal disease. So very uncommon for West Nile to cause a substantial problem, but it can cause a problem. Good news for us is that the infectious period is fairly short, only about 3 to 10 days or so for the infectious period. And the better news is that the window period for the testing that we use, which is NAT, is only 2 to 3 days. So as a result of all of those factors, the risk is pretty close to zero for West Nile virus testing. For West Nile virus, I should say. For testing, as I said, we use NAT, either PCR or TMA, depending on the platform. We standardly use a mini pool, though we switch to individual testing at the time of a trigger, and each blood center has to define what its trigger will be to go to the more sensitive testing, whether that's notification from the health department that West Nile is prevalent in your area, whether it's positive blood donors, whether there's increased amounts of West Nile in mosquitoes and birds. Either way, you switch to individual donor testing at a defined interval, and then you switch back at that defined interval, whether that's 7 days without any positive tests or whatever you choose to do. West Nile virus. Oh, sorry, there is no confirmatory test for West Nile, just the NAT. That's all we have. And deferral with disease, if someone has West Nile, the deferral is actually 120 days from the time of diagnosis. That slide is incorrect, and I'm sorry, I forgot to change that. Without disease, it's 120 days from the time of the positive test. So whichever is later, either from the date of the positive test or from the date of the diagnosis, the individual is deferred 120 days. Another trick that people who write test questions like to throw at you is, because you know that West Nile virus is seasonal, it's easy to get fooled into thinking that as a result the testing must be seasonal, but the testing is actually required year-round, not just seasonal. All right, let's talk about T. cruzi. So Chagas disease is caused by a parasite that comes from the bite of a triatamine bug, or the reduvid bug, as some people call it. But it's actually not the bite. That's true. That's what I actually always thought. But the truth is, what has to happen is the bug has to bite you, and then the parasite is actually transmitted through the feces, and that's just gross. So they bite you, then you get it. Nasty. Anyway, Chagas is endemic in Mexico and South America and Central America. Not so much endemic in the United States, but it is starting to become more of an issue, especially in areas of heavy immigration from Central America and Mexico, such as Los Angeles and Miami and along the border of Texas. Here's our friend the reduvid bug, the kissing bug, as some people call it. I don't like that term anymore. And an image that's a little dim, I apologize for that, for the parasite. This is the parasite on a thick blood smear. Here's how the distribution of Chagas disease looks. Again, Central America, South America, Mexico. And I just had to show you a picture of Dr. Chagas. This is Carlos Chagas in Brazil in 1909, when he was discovering the disease that would bear his name. And finally, here's just a picture of the life cycle. Busy slide. So there's a life cycle on the left side that is in the triatamine bug, and the life cycle on the right side in humans, where trypamastigotes come in, and amastigotes basically sit in infected tissues such as muscles of the GI tract, especially, such as muscle of the heart, and that's what happens with Chagas disease. You get long-term infections with the organisms gradually proliferating in areas of risk. So the acute phase of Chagas is often mild. It's usually asymptomatic, in fact, but the chronic phase is lifelong. And despite the fact that it is usually asymptomatic, individuals may definitely have issues from this. Problems with the heart and the lung, and toxic or infectious megacolon, actually, and megaesophagus. Those things absolutely happen. Damage to those organs as a result of the parasite. And like CMV, the symptoms and manifestations are considerably worse in those who are immunocompromised. There have only been 9 proven U.S. transmissions through transfusion, and 2 of those were just presented at the 2010 AABB. Far less than what you might think, given the fact that there's a lot of Chagas disease out there. According to the data that we have, whole blood and platelet transfusions are the most likely to transmit infection. And in fact, in the United States, since we don't transfuse whole blood very often, all of the U.S. transfusion-transmitted cases were from platelets. platelet transfusions, I should say. The organism lives in stored products for fairly well, at least 5 days for platelets, not very well in frozen plasma, and about 2 to 3 weeks for whole blood. Probably about the same for red cells. In terms of the testing, well, we actually got an approved ELISA test for Trypanosoma cruzi back in December 2006. However, despite the fact that the FDA approved the test, they didn't require the test. But most centers started screening in 2007. And then there was an FDA guidance that came out in 2010, in December of 2010, that has kind of solidified what we're going to have to do now with Chagas. As of 1 year from that, December 2011, which is coming up fairly soon as of the recording of this podcast, we are required to test everyone for Chagas. We're required to test them, however, only once. In other words, if you get a one-time negative for Chagas, you don't have to be tested again. You can choose to go ahead and test everyone again, but you're not required to test everyone more than once. If someone does test positive, you're required to notify that individual, defer them permanently, because there's no confirmatory test that the FDA has given us approval for yet, and you may have to do look back. More on that right here. The look back basically is required if the donor or the mom lived in an endemic area. So as a result of vertical transmission, if there is risk that this individual might actually have Chagas disease, then yes, you're required to look back and notify all people who have received blood from that particular donor for a minimum of 10 years. It's also required, by the way, if other tests show disease. Again, there's no confirmatory test, but if there's evidence of Chagas in other testing that's done, whether that's clinical or laboratory, you're required to do that same look back. All right, so we've gone through a lot. I wanted to show you a summary table of some of the risks that we've discussed so far. Again, please note that HIV risk, 1 in 1,467,000. The number's not quite so good for HCV and not quite so good for HBV, but again, a very, very low risk of most transfusion-transmitted infections. It's a very rapidly evolving field. This podcast is recorded in September 2011. Again, please be aware that things may change, and if you're listening to this and watching this later than that, which is almost certain that you will be sure to check current references and make sure everything's up to date. So we'll see what happens. It's going to be an interesting ride as we go forward, looking for more infectious diseases and seeing how pathogen reduction is going to fit into all this. So I want to thank you for hanging out with me for the last 50 minutes. It's been a lot of fun. I have greatly appreciated the comments that people have given to me as a result of these podcasts. Please comment on iTunes if these were helpful for you, or if they weren't helpful for you. Shoot me an email. Go to www.bbguy.org. And thanks again for hanging out. I've appreciated it, and I will see you the next time on the podcast.